next topic is about chronic venous insufficiency or post thrombotic syndrome, which results from the obstruction of the venous valves in the legs or a reflux through the valves.
Valves in the leg veins are not working effectively, making it difficult for blood to return to the heart from the legs. Chronic venous insufficiency, or CVI, causes blood to pool or collect in these veins, and this pooling is called stasis. Majority of the patients having valvular dysfunction have no primary etiology. Here are the risk factors for chronic venous insufficiency. First is family history, which is the most important risk factors. CVI occurs mostly on females more than males since due to pregnancy and hormones. Another is obesity. It occurs mostly when one reaches over age of 50. One or more blood clots in superficial or deep veins. Chronic venous insufficiency that develops as a result of DVT is also known as post-thrombotic syndrome. As many as 30% of people with DVT will develop this problem within 10 years after diagnosis. Sitting or standing for long periods. Normally, valves in your deeper leg veins keep blood moving forward towards the heart. With chronic venous insufficiency, vein walls are weakened and valves are damaged. This causes the veins to stay filled with blood, especially when you are standing. Pathogenesis of CVI or chronic venous insufficiency. The passage of blood upward from the feet against gravity depends on calf muscles to push the blood upward and to keep the blood flowing up and not back down. The veins contain one-way valves. The calf muscles act as a pump which ensures blood flow from superficial to deep system. However, this is only possible when there are competent venous valves. The calf muscle pump or musculovenous pump is thought to function as peripheral heart. When the valves fail to close properly, gravity wins and the flow reverses, which is what we call as venous reflux. Defective valves cause a buildup of pressure of the blood in the leg, leading to venous hypertension. The transmission of excessive pressure to the dermal microcirculation is the primary driver of the chronic inflammatory processes observed in CVI patients. Here are the clinical manifestations for CVI. Bulging veins, leg swelling, skin color and texture changes, venous ulcers, swelling in the lower legs and ankles, aching or tiredness in the legs, leathery looking skin on the legs, flaking or itching skin on the legs or feet, and stasis ulcers. Here are the complications for chronic venous insufficiency: cellulitis, peripheral neuropathy, leg swelling, either in the unilateral or bilateral, worsening of varicose veins, skin abscess on the legs or feet, skin ulcers on the legs or feet, stasis dermatitis, deep venous thrombosis.
Here are some diagnostic tests for CVI. First is vascular or duplex ultrasound, which is used to examine the blood circulation in the legs. During the vascular ultrasound, a transducer or a small handheld device is placed on the skin over the vein to be examined. The transducer emits sound waves that bounce off the vein. These sound waves are recorded, and an image of the vessel is created and displayed on a monitor. Another is venogram. Contrast dye causes the blood vessels to appear opaque on the X ray image, which helps the doctor see them on the image. This dye will provide a clearer X ray picture of the blood vessels. Pharmacologic therapy for CVI. So, here are some medications which are prescribed to patients with CVI. First is diuretics, in which these medications draw extra fluid from your body that is then excreted through your kidneys. Then anticoagulants, which are medications that thins the blood. The next is pentoxifylline, a medication that helps improve blood flow, and then aspirin, which is used to help ulcers heal.
Here are other medical managements for CVI. First is endovenous laser ablation or radiofrequency ablation. This is a minimally invasive procedure. A tube puts heat right into the affected vein. This closes the vein. Once the vein is closed, less blood pools in the leg. Overall blood flow is improved. Next is sclerotherapy. This may be used if the case is more serious. A chemical is injected into the affected veins. The chemical causes scarring in the veins so that they can no longer carry blood. Blood then returns to the heart through other veins. The body absorbs the scarred veins. Next is surgery. This is done in severe cases. Ligation is a type of surgery that may be used. The affected vein is tied off so that blood no longer flows through it. If the vein or its valves are heavily damaged, the vein will be removed. This is what we call as vein stripping.
Patients with chronic venous insufficiency should be treated based on the severity and nature of the disease. The treatment goals for CVI includes reducing discomfort and edema, stabilizing skin appearance, removing painful varicose veins, and healing ulcers. Measures that increase blood flow are anti-gravity activities such as elevating the leg and compression of superficial veins with graduated compression stockings. Elevating the legs decreases edema, promotes venous return, and provides symptomatic relief. Compression of the legs with graduated compression stockings reduces the pooling of venous blood, enhances venous return to the heart, thus recommended for venous insufficiency treatment. Extremities with venous insufficiency must be carefully protected from trauma. The skin is kept clean, dry, and soft. Signs of ulceration are immediately reported for treatment and follow-up. Here are some nursing diagnoses with its nursing interventions for chronic venous insufficiency. First is ineffective tissue perfusion related to reduced vascular circulation. Its interventions include instruct the patient in measures to improve circulation, which is to exercise moderately, elevate the legs above the level of the heart when resting, avoid smoking, avoid prolonged periods of walking or standing still. Another is to assess the condition of ulcer, peripheral pulses, skin color, warmth, pain, and edema. Lastly is to teach wound care as ordered. Other nursing diagnosis for CVI is impaired skin integrity related to stasis, dermatitis, and ulcerations. The interventions for this are first is to inspect for dermatitis and ulcerations. Patient education is critical because these ulcerations are frequently treated on an outpatient basis. Instruct the patient and family in the management of the ulcerations while in the home setting. A referral for home health care may be appropriate. Last nursing diagnosis I included for CVI is risk for infection related to compromised circulation and impaired skin integrity. Carefully monitor for signs of infection such as elevated temperature, chills, general malaise, and localized redness, pain, and purulent drainage. Teach the patient through hand washing, good hygiene, and appropriate wound care. The fragile edematous tissue also must be protected from trauma to avoid creating portals for pathogens.
Prognosis for chronic venous insufficiency. CVI is not a benign disorder and carries enormous morbidity. Without correction, the condition is progressive. Even with treatment, recurrences are common if venous hypertension persists. Nearly 60% develop phlebitis, which often progresses to deep vein thrombosis in more than 50% of patients. The venous insufficiency can also lead to severe hemorrhage. Surgery for CVI remains unsatisfactory despite the availability of numerous procedures. The cost of care to the patient is enormous.
So that's it for both topics. I hope you learned something about venous thromboembolism and chronic venous insufficiency. Thank you and have a good day.